Alright, Chapter 43. We're going to be talking about trauma systems and the mechanism of injury, and this will start leading us into our whole section on trauma, and at some point eventually doing a PHTLS class. If you look at the epidemiology of trauma, or what sort of mechanisms are involved in traumatic injury, you can see the vast majority of them, 32.3%, are motor vehicle collisions, and we don't call them motor vehicle accidents anymore because by and far the majority of them are preventable. They aren't accidents. There are certainly a result of acts of omission or commission. Second to that is firearms, and then other falls, poisonings, drownings, burns, that sort of thing. But motor vehicle by far is the most common cause of trauma here in the United States. And the cost is huge because the vast majority of people in motor vehicle collisions are young, and if they are permanently disabled or die as a result of their collision, there's a measurable loss of years of productive life, a huge financial impact on our society, and then the emotional effect of losing people that young. We kind of addressed in the earlier slide the different mechanisms of trauma, with motor vehicle collisions being the most prevalent. Falls remain the leading cause of death in the elderly patient. Poisonings in children, unintentional, and a small percentage of intentional poisonings. Firearms actually, since this slide deck has been produced, death by firearms here in the United States, in most states, even those with relaxed laws allowing for concealed carry, show death by firearms decreasing. When we look at the overall increase in penetrating trauma, they relate that to firearm violence, but short of stabbing with an ice pick or a knife, that's about the only other way penetrating trauma occurs. The phases of trauma begin with the pre-event, and this is where injury prevention comes in, because we know that most all trauma is not accidental. And in the pre-event is where we focus things like public education activities, to educate the public on the perils of driving drunk, the perils of driving fast, the perils of driving without seat belts, those sort of things. Most people who die from trauma immediately within the first several minutes of their insult either hemorrhage to death internally, or have a fatal wound or a mass brain injury or brain stem injury. And we can't fix that when we arrive on scene if that's the mechanism. The only true way to fix it is to prevent it from ever happening. Then you have the event. That's where we're interacting with people, we're demonstrating our professional attributes as EMS providers, caring for those, and one of the most trusted professions in the world is a paramedic, and trusted not only because patients allow you to do a lot of things to them, but they also look up to you as a mentor, and as such, if you're able to demonstrate good safety practices yourself, with wearing helmets and riding bikes and buckling up and not drinking and driving and obeying the speed limits and those sort of things, you can lead by example. Other things that you could do include bicycle rodeos, child safety seats, seatbelt courses like where you go into a driver's ed program and you show them all the gory slides and tie them to stories about driving fast, driving intoxicated, not wearing seatbelts, those sort of things. Post-event is where we get the 911 call, and during that particular time, we hope to provide optimal patient care. And optimal patient care is yet to be defined when it comes to trauma patients. We know that the amount of time that we have with them is extremely limited, especially if they have a time-critical injury, and that requires us to do a very quick assessment, make some appropriate clinical decisions, decide what sort of treatment we can do on scene and what sort of treatment we can do en route to the hospital, and the post-event continues until the patient is delivered to the emergency department and your run report is complete. The trauma system is in Iowa, as well as many states, has multiple inner working parts. Injury prevention is one. We have an injury prevention specialist down at the state who helps us with injury prevention initiatives. A trauma system includes the pre-hospital care, from the first responder all the way through the paramedic, as well as what occurs in the emergency department. Getting patients to the correct hospital in the shortest amount of time safely is the whole focus of a trauma system. Inter-facility transports, if we've got a community-based facility that does not have surgical capabilities and our trauma patient needs surgery, then we have to be able to, again, to get them there quickly and safely. Definitive care, the definitive care for a trauma patient is surgery and blood, and we can't do either of those in the pre-hospital environment. So when we have a trauma patient with a time-critical injury, it's very important that we get them to a facility where they can get both surgical intervention and blood. Rehabilitation and data collection and trauma registry. The state has a data collection where all those services who are using the state-provided patient care report, that information, particularly related to trauma, is being downloaded into a registry where we as like one of my roles as the chair of the Emergency Medical Services Advisory Committee is to look at that information from time to time and see how we are caring for trauma patients here in Iowa. I'd mentioned getting the patient to an appropriate facility capable of handling their needs, and in trauma systems they've divided trauma centers into 4 levels. Iowa has moved away from using the word level because a level 1 certainly would indicate that, well, that would be much better than a level 4. And we don't want people to think that a level 4 is not capable of initially stabilizing trauma patients and moving them to a level 1 or 2. So we use the term resource, regional, area, and community. So a level 1 resource trauma care facility is just that. It's a regional resource center. It provides all trauma services, has surgeons of all types, and what sets a level 1 apart from all others is that those services, those full services, are in-house 24/7, and as a level 1 trauma care facility, they are involved in research. We have one level 1 trauma care facility, and that is the University of Iowa. Level 2 trauma care facilities, or regional trauma care facilities, are able to provide comprehensive trauma care. They don't have all the resources that a level 1 has. They may have all the resources, but those resources may be on call and not in-house 24/7. And they don't conduct any research. Level 3 or area trauma care facilities are communities that don't have a level 1 or level 2. They do provide evaluation, resuscitation. They do have operative intervention and are able to stabilize trauma patients. So, a level 3 or an area trauma care facility, an example would be St. Luke's or Unity Point in Sioux City, Iowa. They're a level 3, where Mercy Medical Center is a level 2. Level 4 are community trauma care facilities, and these are rural, remote, critical access hospitals, less than 100 bed hospitals, and they provide initial stabilization, and then we'll transfer them on to an appropriate level depending upon the patient's needs. Now, this particular map shows you where all the Iowa trauma care facilities are as of March of 2014, and of course they haven't changed. I guess we do have 2 level 1 trauma care facilities. I'd forgotten the Iowa Methodist, which I believe is now Unity Point, in Des Moines, does some research, and so therefore is a level 1 trauma care facility. So you have one in Des Moines and you have one in Iowa City. The area, the level, let's go with level 2 trauma care facilities. With the diamond, we have the one in Woodbury County, which would be Mercy. We have one over in Cerro County, which would be Mason City. One, of course, in Des Moines, which would be Mercy. One over in Scott County. So not very many. And then you look at area or level 3 trauma care facilities. We have Unity Point in Woodbury County. We have both the hospitals in Council Bluffs, our area level 3 trauma care facilities, and I would imagine that's because just across the river are level 1 or 2 trauma care facilities. But they're dotted all over. You can see the vast majority of all hospitals in Iowa are community or level 4 trauma care facilities. When we think about transport considerations, when we have a patient who has a time-critical injury, and here again we're only talking about 5% of all our trauma patients, but if they do have a time-sensitive injury, a life-threatening injury, where they need surgery or blood, time is the single most important factor. We're all familiar with the term golden hour. That was Dr. Crowley and his friends at the Baltimore Shock Trauma Center came up with that whole, boy, if we can get the patient on our operating table within an hour of the injury, doesn't matter what the injury is, we have a really good chance of saving their life. EMS then picked up what was called the platinum 10 minutes of that hour. So when we have access to a trauma patient with a potentially time-critical injury, we should spend no more than 10 minutes on scene. I think it's important to note not to sacrifice care for speed. When we talk about stay and play, load and go, load and go, we can do that without compromising patient care. It's not scoop and haul ass or anything like that. It's provide initial life-saving care, which can be done quickly. As an example, controlling severe hemorrhage, opening an airway, ventilating the patient, providing them oxygen, that sort of stuff, and then move them to the ambulance and down the road where things like IVs can be started, monitors can be applied, meds can be given, those sort of things. The most appropriate facility may not be the closest facility, and we have an out-of-hospital trauma triage destination decision protocol in Iowa that drives or guides us as to where we're to take these patients. For us it's not an issue because we have only the one facility in our county, so we're 120 minutes in any one direction from a level 1 or 2 trauma care facility. So we've got to take the patients back to our facility where they're transferred on. But when you get into areas like, let's say, Lamar's, and you're south of Lamar's on Highway 75, and there's a major accident, and you have a patient with a time critical injury, and the helicopters aren't flying, then um, you know you may, rather than go 5 minutes back to your hospital, take the patient directly to Mercy in Sioux City. Um, Ground transportation certainly is adequate if it's reasonable. Um, generally, if you can get to a trauma care facility within 60 minutes by ground is often more reasonable than flight. And protocols like the out-of-hospital trauma triage destination decision protocol for Iowa um, don't address how far away you are per se. Well, I guess they do. They look at if you're within 30 minutes. If you're within 30 minutes of a level 1 or level 2 trauma care facility, you go directly to that facility, even if it means bypassing your own. And that might be a little tricky for where you're at as well. If you've got 2 level 3s sitting there and you're 10 minutes away from a level 1 or 2, and you have a patient with a time critical injury, do you cross state lines, or do you take them to the level 3 trauma care facility? Local protocols will dictate that. Air medical transport, when time critical for the patient conditions. If you've got long extrication times, certainly a scene flight might be appropriate. If you're in heavy traffic and you know that you're going to be delayed, air care might be more appropriate. And if you don't have critical care personnel on your ground ambulance. By calling a helicopter, we certainly may get the patient back to a facility faster, while being cared for by those people with critical care training and experience. But what I see air medical transport being used for frequently is to staff a vacant need. Don't have a truck, don't have staff, don't have that nurse to pull off the floor and put in the back of the ambulance to go with this critical patient, or that respiratory therapy person. So they're calling for a helicopter, even though that may not be the fastest method of getting a patient to a level 1 or level 2 trauma care facility. So let's talk a little bit about trauma and how it occurs. And trauma or injury is all about the exchange of energy. And there are some physical laws that we must consider or think about when talking about the energy of trauma, which is known as kinetic energy. We look at Newton's first law of motion, and Newton's first law of motion says that let me think. A body at rest will stay at rest, and a body at motion will stay in motion until acted upon by some outside force. And what this means is that if I am at rest, I'm at rest, and there's no exchange of energy. But if I'm in motion, if I'm in a car and the car is going 55 miles an hour, then I am going 55 miles an hour. And I will continue to go 55 miles an hour until acted upon by some outside source. Now, in a motor vehicle, I'm going to apply my pressure to my brake pad, and that would be the outside source that would slow the vehicle down. Well, as the vehicle slows down, I slow down as well. The conservation of energy is a theory that says energy cannot be destroyed. It just changes form. So an example there is the energy of motion, which is kinetic energy. The energy of motion, while I'm in that car and I'm going 55 mile an hour. Car's going 55, I'm going 55. When I apply pressure to the brake pad, that energy of motion is changed into heat energy as the brake pads heat up, slowing down the vehicle. But let's say I'm in that car going 55 mile an hour, and all of a sudden I hit a bridge abutment, and the car stops suddenly. Well, I'm still going 55 mile an hour until acted upon by some outside force. Now, if the airbags deploy and my seatbelts are adjusted and worn properly, then those things would absorb that energy. If I'm not belted and I don't have airbags, then my body is going to slam into the steering wheel, or fly out a window, or ram my head into the windshield, and that's going to be the outside force that I hit. And the energy then isn't destroyed, it is changed into damage energy, or tissue damage energy, what we call trauma. Kinetic energy equals the mass of the object times the velocity of the object squared. And the important thing to remember here is that it's not as much the weight of the object as it is how fast it's going that we need to pay attention to. Velocity influences more than mass, because you can see in this equation that you take the speed of the object and you square it. You take it times itself. And so what that means to me as far as kinetic energy is, let's take just for sake of argument, let's take a 100-pound person going 10 mile an hour. Well, you got a 100-pound person, so you got 100 times 10 squared, or 10 times 10, which is 100. So you have 100 times 100, which is 10,000. So a 100-pound person going 10 miles per hour, should that vehicle slam into a cement wall, would be exposed to 10,000 kinetic energy units. And if you want to pick something to represent a kinetic energy unit, 10,000 pencils, 10,000 bricks. Since we're talking about damage and trauma, I liken a kinetic energy unit to a stick of dynamite. So this person would be, this 100-pound person going 10 miles per hour would be exposed to 10,000 kinetic energy units. Now let's take that same 100-pound person, but now they're going 20 miles per hour. I only increased the speed 10, but now it's 20 times 20. And 20 times 20, when I do the math, is 400. So if I take 400 times 100, then I end up getting 40,000 kinetic energy units. I only increased the speed by 10, but I've quadrupled the kinetic energy units that my body would be exposed to should I have to stop suddenly. So that's what that's all about. Now we look at force. Force equals the half of the mass of the object times the velocity of the object squared. And velocity again influences more than mass. So with kinetic energy and force, the thing to keep in mind is speed kills. The faster something goes, the more damage it's going to cause when that energy has to be absorbed or transferred. So in summary, as far as the energy laws go, motion is created by force. Force must stop motion, and the energy exchange is going to result in tissue damage or trauma. Kind of like a pool ball when you're playing pool. That if you hit the cue ball and it smacks right on the top of that rack, you can see how the energy is transferred to ball to ball to ball to ball to ball, causing the balls all to spread out. Cavitation is something else that we need to consider when dealing with energy. Cavitation is an opening produced by force that pushes tissue laterally away from the track of the projectile. Now here they're showing a demonstration of a bat, where, if I hit somebody with blunt trauma with a bat, blunt trauma, the energy is spread out over a larger area, and when I hit somebody with a bat, it's going to create a cavity, but that's a temporary cavity. When I'm finished hitting somebody with a bat, the tissue comes back to normal, and if I had not assessed that area or paid attention to that area, I might not see the decap BTLS and know that beneath that tissue there could be some major organ damage. Cavitation depends on speed and the density of the object, a bullet or a bat. The effect depends on the density of the object sustaining the impact, and the body density types affect the cavitation as well. Whether the projectile is traveling through air, water, or muscle or bones. Again, the cavity can be temporary, as in the case of hitting somebody with a bat with some causing soft tissue injury, or it can be permanent, as in the case of a projectile with a exit wound. Dependent factors on energy exchange include the density of the tissue, the shape of the projectile. The energy moving through different types of organs and tissues creates different results. The point of impact certainly determines energy exchange. And what they mean here when they're referring to point of impact, a point of impact, let's say I fall off a roof. If I land on my feet, that's the point of impact. And you'd expect perhaps fractured heels, those sort of things, but that energy can be transmitted up my legs and potentially fracture my pelvis, dislocate my hip, and then the weight of my torso, pushing down on my spine when I hit the ground on my feet can cause low back fractures, those sort of things. And then if I fall forward on outstretched hands, I can fracture my wrist, dislocate my elbows, fracture my clavicle, all those wonderful things. So point of impact is an important consideration concerning energy exchange. Here's an example of a temporary cavity as the projectile travels through the body. A temporary cavity is created, but when it is complete, when it's done, there remains a much smaller cavity. The cavitation that occurs with a projectile depends on the speed of the projectile. Medium velocity projectiles, those that come from handguns, the cavity will be 5 times the size of the projectile. But when you're dealing with high velocity munitions, like with rifles, the cavity, because of the speed of the projectile, the cavity is often 15 times the size of the projectile. Kinematics is the process of predicting injury patterns based on the mechanism of injury. It requires you to understand the force of the energy applied, the anatomy it was applied to, and the type of energy that you're dealing with. Kinematics should give you a high degree of suspicion that the patient may have suffered a time-critical injury. But by itself, it is no reason to call a trauma alert or get everybody all worked up or get a helicopter in the air just because a person has sustained a particular type of injury. We've all seen those patients who have suffered an injury, and because of proper safety equipment, they've been in this motor vehicle collision, and you look at the vehicle and you go, oh my gosh, nobody could have survived that, and the person's up and walking around and is fine. So Mechanism of injury should give you a high index of suspicion of a time critical injury, but you have to combine that with your physical exam in order to determine whether that is in fact true. Blunt trauma can be shear or compressed. Shear forces result from a speed difference, where one part of the body moves slower or faster in relationship to the other, kind of like not necessarily a twisting, but a change in direction at either a slower or faster speed. Shear injuries include the ligamentum arteriosum holds the heart inside the chest, and during a rapid deceleration, the ligament acts like a cheese slicer, and as the heart is hurled forward during a rapid deceleration, the ligament remains stable while the heart is thrown forward against it, and it severs the aorta, causing a massive exsanguinating hemorrhage. Compression, that's where the force is directly applied to an organ or body part. Certainly the length of compression time, the force of compression, and the area compressed all have to be considered to determine the type of injury. Vehicle collisions can be front or head-on impacts, and in those particular situations where you arrive on scene, you see some major front-end damage on a vehicle, you know that there's been a frontal impact. Unbelted patients will take one of two pathways. They'll slide down and under the steering wheel, or they'll go up and over the steering wheel. If they go down and under, the occupant continues forward, moves downward in the seat. The knee is the primary impact point on the dash. The tibia can be fractured. The knee can be dislocated. The popliteal artery lies behind the knee. That can be damaged and maybe even potentially cause a blood clot. The femur can be impacted. The femur can fracture. The hip can dislocate. The pelvis can fracture. Again, blood clots. And the injuries may be subtle. Here they're showing you that down and under impact. When you arrive on scene and you look inside the vehicle at the dash, and the dash is all broken and cracked, and you're thinking, oh, well, that had to be part of a collision. What did that? Well, often an unbelted passenger will do that. Up and over pathway, the patient impales themselves on the steering wheel and goes up and over the steering wheel. The head is propelled into the windshield, into the roof. So expect when you arrive on scene, what you're going to see here, of course, is a starred windshield. And that windshield was starred, or that windshield was fractured as a result of the patient's head hitting the windshield. But the abdomen can be compressed against the steering wheel. The chest could be compressed against the steering wheel, leading to all sorts of liver and spleen injuries, ruptured bowels, pneumothoraxes, all those sort of things. When the head hits the windshield, certainly you can have skull fractures, cerebral contusions, brain stem stretch or shear, brain bleeds, compression fractures of the cervical vertebrae, hyperextension injuries or hyperflexion injuries depending upon what part of the head hits the windshield. Chest, you can have fractured ribs, pneumothorax, hemothorax, combination of both, a myocardial contusion, rupture of the heart, rupture of the aorta. The abdomen, you can have a diaphragm tear, you can have an abdominal wall tear, liver can be ruptured or torn, avulsions, those sort of things. You can again rupture the intestine. The mesenteric vessels can be avulsed. Gallbladder can rupture from a compression or shear injury as well. T-bone accidents, where the patient is T-boned by another vehicle, or where the collision is on the side of the vehicle, the patient is propelled away from the impact point, which often can cause a shear injury. With lateral side impacts, you can have skull fractures, cerebral contusions, hemorrhage, brainstem stretch. On the opposite side of the head, neck compression, odontoid fractures, and that is C1, C2, where the head may twist towards the injury while the body is being thrown in the opposite direction of the impact. And this doesn't take into account, lateral side impacts doesn't take into account, an occupant, an unbelted occupant in the same seat, because then you get a double whammy there. You can have rib fractures on the side, pneumothorax, hemothorax, spleen or liver, depending on which side is impacted, thoracic vertebrae fractures, aortic shears, compression of the liver or spleen, kidney injuries, diaphragmatic tears, diaphragmatic herniations, all sort of vessel shears, pelvis, femur fractures, clavicle fractures. With rear end impacts, the head is a 22-pound heavy weight on a broomstick, and when the vehicle is struck from the rear, the body shoots forward while the head snaps back, causing a hyperextension injury, which we know as whiplash. So hyperextension injury with possible ligament and tendon tears and stretches, minimal injury to the torso, minimal injuries to the extremity, unless the vehicle shoots forward and then hits something head on. Then you have both a rear impact and a frontal impact. Rotational impact, that's kind of an offset. Someone struck in the rear quarter panel or front quarter panel instead of directly in the center of the vehicle. With a rotational impact, the vehicle spins around and around and around, and it's kind of like a carnival ride. It's pretty fun for a while, but when the vehicle stops, you're still spinning at that particular speed, and you'll slam into whatever if you're not belted. And you can suffer skull fractures, brain contusions, brainstem stretches or shears, compression fractures of the cervical vertebrae, hyperextension or hyperflexion injuries, odontoid fractures, rotational injuries. The chest and abdomen, all the same things that you saw with the other two types of impacts. GI and gallbladder, same as with the frontal impact. Same thing with the pelvis and the extremities. Restraints are going to be your best bet of surviving a motor vehicle collision, because the lap belts hold the torso close to the seat, away from the dashboard and the steering column. Lap belts prevent ejection, but they do not support the upper torso. That's why we've added lap belts and shoulder restraints together. If they're worn incorrectly, particularly a lap belt, if it's worn high above the pelvic girdle around the abdomen, it can cause injury to liver, the spleen, the duodenum, the pancreas, and even compression fractures of the spine. Shoulder restraints, in addition with lap belts, prevents injury to the upper torso and the head, prevents hyperflexion of the body at the waist. If you just wear a shoulder restraint and not a lap belt, and there used to be vehicles out there where you had a lap belt and a shoulder restraint, and they were not one thing. You had to latch them both separately. Well, in situations like that, some people would just put the lap belt in because they didn't like where the shoulder restraint rode against their chest, or they just put the shoulder restraint on. And when you put just the shoulder restraint on, during a collision, you can go down and under, and that shoulder strap can catch your head, and I've seen it pop the head right off a person and pop the head right in the back seat. So there aren't many vehicles out there anymore where you have an option of one or the other. You just get them both. Airbags, we know that there's all types of airbags, air curtains. They're in the steering columns, in the dash, in the side posts, and they will provide you supplemental protection along with your lap and shoulder belts. They can cause injury to the driver if you're within 10 inches away, or if the passenger's within 18 inches, or closer than 18 inches to the airbag. But typically, those type of injuries are not lethal. May break glasses, may have some facial trauma, small abrasions. There has been the Ducata factory where they've had to recall all those airbags because they've been deploying too fast. That was problematic. There have been some deaths reported as a result of that too much force when a person is too close to it. So they're recalling all the airbags there. Children, certainly small children in a front seat, the airbags were deploying at too great a speed and too fast, causing severe trauma and death to children. So manufacturers came up with ways to either shut the passenger airbag off when you had a child in the front seat, or sensors in the seat that would sense the weight of the individual and then calculate the speed of deployment of the airbag should it need to be deployed. Child safety seats. When a child is fitted properly in a child safety seat, they shouldn't receive any injuries. However, if they're not fitted properly, just like an adult, if the lap belt is worn too high over the abdomen, they can suffer abdominal trauma. They can have acceleration and deceleration injuries, neck and spinal cord injuries as well. The manufacturers of child safety seats only guarantee them to work for one collision. So after a crash, those child safety seats should be replaced, and they often aren't. I knew a paramedic who got in a bit of trouble knowing that these child safety seats were not replaced often, that at the scene of a motor vehicle collision, he would intentionally cut the straps off the child safety seats so they would have to be replaced. Electronic stability control system use things like anti-lock brakes to help decrease power to selected wheels to prevent crashes. Here is an example of a lap belt worn above the pelvic girdle, and during a rapid deceleration, compression of the abdomen leading to all those things that we've talked about. Deceleration injuries, you can end up with what's called a coup contra coup injury, where during a rapid deceleration, remember, if you're in that vehicle going 65 mile an hour, you're going 65 mile an hour and your brain's going 65 mile an hour. If the vehicle stops suddenly, you're still going 65 and your brain's still going 65. If you smack your head on the windshield, well, then you're going to have trauma there, but then the brain is still going 65 until it's acted upon by some outside force, which would be the inside of your skull. So it slams onto the inside of your skull, causing a bleeding or bruising of the frontal part of the brain. However, in doing so, when it slides forward, it stretches and tears the vasculature, vessels and things on the back side of the brain, causing a contra coup injury. Deceleration injuries, you also have to remember, we talked earlier about the aorta, how it can be sheared, and the same thing occurs with all your major organs in your mesentery. All of those organs are held into place by ligaments, and during a rapid deceleration, those organs can roll forward against those ligaments, which act as like a cheese slicer and slices them in half or slices them up. Compression injuries include open and closed skull fractures, facial fractures, soft tissue injuries, bone fragment penetration into the brain, hemorrhage from fractured bones, meningeal vessels and arteries. Um, when you have somebody with a serious head injury following a motor vehicle collision, you must also consider the potential for a cervical fracture. Remember that in motor vehicle collisions there can be hyperextension and hyperflexion injuries. Um, Compression injuries during blunt trauma include rupture of the lungs. And this occurs when, let's say, in a motor vehicle collision, right before seeing the accident, people will often take a deep breath and close their glottis. And then when the accident occurs and their chest slams on the steering wheel, that compression of the chest against that closed glottis causes the lungs to rupture, and you end up with bilateral pneumothoraces. The heart can be compressed, the aorta valve can rupture, you can get a myocardial contusion. In the cases with a myocardial contusion, patients will present with cardiac dysrhythmias, chest pain, often much like a STEMI. They can have atrial or ventricular valve ruptures, cardiac tamponade, and we know that tamponade is present when we see things like narrowing pulse pressure, jugular vein distension, muffled heart tones, those sort of things. You can have fractured ribs, and of course, if the ribs are fractured, that's not for me the big issue. It's the tissue damage that's done underneath. Sherry posted on Facebook a significant flail segment that this person had in a video, and you could clearly see the flail, so you knew that there was a big chunk of free-floating ribs on that chest. But more importantly, underneath there was an excessively large pulmonary contusion as well. Rib fractures can lead to pneumothorax and hemothorax. With compression injuries, when you compress the abdomen on the steering wheel, compress the abdomen against the seat belt, your solid organs can rupture, your hollow organs can dump all their contents into the peritoneal cavity, your bladder can rupture, you can get lacerations of the liver, spleen, kidney, you can rupture the diaphragm and herniate your stomach and intestines up into your lung. Here's just trying to illustrate that aortic tear as a result of the ligamentum arteriosum that holds the heart in place, and during a rapid deceleration it'll roll forward against that ligament, causing a tear in the aorta. There's a tear in the artery supplying the kidney. There's that paper bag syndrome is what it's called. Right before an accident, you take a deep breath and hold it, and then when you smack your chest on the steering wheel and your chest is compressed against that closed glottis, it's like popping a paper bag. You pop your lung. Motorcycle collisions, you can have frontal or head-on impacts with a motorcycle that propels the rider over the handlebars. They can suffer head and neck injuries. They can have compression to the axial skeleton, the chest, the abdomen. They can have bilateral femur fractures if their legs catch the handlebars on the way over, and then perineal injuries as well. Here's an example of the up and over with bilateral femur fractures. You can have an angular impact with crush injuries where the motor vehicle is alongside the motorcycle, and one veers into the other, crushing the driver's leg against pinning the leg between the car and the motorcycle, causing a crush injury or impalement of the mirror or door handle or something like that. Laying the bike down is perhaps one of the worst things that a cyclist can do, and those who have ridden a long time and have understood the psychology here, when you lay a bike down, you have absolutely no control over the bike itself. You're far better off to brake hard, try to steer away from the injury, and if you can at least get slowed down prior to the impact, injuries may be less. But laying the bike down, massive abrasions, fractures, and you have no steering or no control of the bike, and often slam into the object at a greater rate of speed. And remember, it's speed that kills. Personal protection and gear for riders: helmets, leather boots, eye protection, leather clothing. I've always said that good thick denim and leather is much less expensive than skin. Like this. This gentleman evidently slid down the highway on his back, and not sure what he was wearing, but oftentimes if you're wearing a leather jacket, this sort of thing doesn't happen. Pedestrian versus a motor vehicle is something else we should consider as well. In this mechanism of injury, you're going to have multiple impacts. The vehicle bumper strikes the pedestrian. The pedestrian is thrown up onto the hood. There's a second impact, and then a pedestrian bounces off the hood and strikes the ground. There's a third impact, and then if the person is run over by the vehicle, that's a fourth. The adult pedestrian typically will have lateral or posterior body injuries, and that's because when an adult sees a vehicle that's about to strike them, they'll turn to the side to try to run away. Children, on the other hand, will face the vehicle because they don't understand the danger. Kind of like a deer in the headlights. They just turn and face the vehicle and freeze up. With the adult, because it strikes them on the lateral side, they can have pelvis, femur, thorax, spine fractures, head and neck when they smack the hood of the car or take the windshield out. And the head and neck can lead to intracranial hemorrhage or internal hemorrhaging inside the body, fractures of all types. So here's an example of one mechanism. The adult is hit laterally, and depending on the size of the bumper and the size of the adult, you might know where that first impact is. Thrown up onto the hood, maybe into the windshield, and if is then thrown to the ground and run over by the vehicle, those are all impacts that we should consider. Children, mostly frontal injuries. Again, they turn and face it, so you can have all types of injuries. Waddell's triad refers to the initial impact, thrown to the ground, and then being run over. So there we go. Frontal impact, maybe thrown up on the dash, thrown up on the hood, depending upon the size of the child and where the bumper is in relationship to their injury, or maybe slide off and then be run over. Or if the bumper's high enough and the child's short enough, it may just go right up over the top of them rather than throw them up onto the hood. And we've seen that as the height of the bumpers has increased with the SUVs. Sports injuries can also lead to blunt trauma. Sports these days, particularly football, the mechanisms and the speed are there for compression injuries, shear injuries, rapid deceleration injuries. So, depending upon which part of the body was impacted first, might give you an idea of the type of injury that you're going to deal with. Vertical falls, you need to consider the height of the fall. Typically, if it's more than 3 times the person's height, that person could have suffered a time-critical injury. The impact surface, what did they land on? Did they land on a pile of hay or a slab of concrete? Did they strike anything on the way down? And which part of the body was the first part to impact the surface? Again, if you fall off that roof and you land on your feet, you could have heel fractures that could be transferred up and breaks anywhere along the lower legs, or dislocation of the hip, fracture of the hip, compression fractures of the spine from the weight of the torso being driven down on the spine. And then if you fall forward on outstretched arms, then you got that whole thing with dislocations and fractures anywhere along the arms, to include the clavicles. Blast injuries, there are 2 types of explosives that we deal with. One is high order explosives, and they produce a supersonic overpressurized shock wave, which is the primary injury in blast. Along with that supersonic overpressurized shock wave is a tremendous amount of heat, and in a high order explosive, depending on how close you are to the blast, you may experience that wave compressing any airfield compartment in your body to the point that it causes trauma, and ruptures eardrums and burns the clothing right off the body. Low order explosives, they create a subsonic explosion. They do not produce the overpressurization, but a low order explosive inside a building, if it doesn't blow the walls out, that wave can be amplified up to 20 times normal, which could then work as a high order explosive. There are 4 types of blast injuries that you're going to deal with. The primary blast injury is the result of the pressure wave rapidly spreading away from the explosion in all directions. It increases intensity with strength of the explosion detonated. We see it with high energy explosives, and these positive and negative pressure waves are going to compress any gas filled pockets in your body. So primary injuries caused from blast injuries include blast lung, which are essentially massive pulmonary contusions, blast abdomen, any air in your colon or any air in your intestines can cause rupture of those organs. You can get traumatic brain injury from the supersonic pressurized wave, and then you have the heat in there as well. So here they're showing you primary injury is number 1, secondary injury is from flying shrapnel, the tertiary injury is from being thrown to the ground from the wind, which is different than the wave, and then quaternary injury, which they aren't showing here, is fallout from things like radiation, dust, and exacerbation of your medical conditions. As we had mentioned, during a primary blast injury, your gas-containing organs are going to be affected. You're going to have pulmonary contusions, your GI tract, your ears will rupture, and traumatic brain injury. Some common things that you'll see as a result of a primary blast injury include hearing loss. So if you arrive on scene of a blast injury and a person has suffered hearing loss, you know that they've been exposed to that supersonic wave, and that they could have pulmonary contusions with pulmonary hemorrhage. They could have a cerebral air embolism. They could have abdominal hemorrhage going on, a bowel perforation, and if close enough, will have burns as well. Secondary blast injuries, the victim is struck by flying debris, so they're going to have lacerations, fractures, they're going to have penetrating injuries, and remember, if the flying debris is a nail, or it can be driven deep into the body and leave just a very small puncture wound. So even small puncture wounds, we don't know what caused that until we get a further assessment, even perhaps an x-ray. We should be diligent in insisting that a person with multiple puncture wounds, even though they don't feel so bad, to have those checked out, because they could be impaled nuts, bolts, nails, those sort of things. Tertiary blast injuries, the victim is propelled through space by the explosion, strikes a stationary objects, or is thrown forcefully to the ground. So it's similar to a vertical fall or a motor vehicle collision. The deceleration causes more damage than the acceleration, because the deceleration is more sudden. You can have abdominal wall injuries, CNS system, musculoskeletal system injuries as well. Quaternary blast injuries are caused by other environmental effects of the explosion, like the heat, the structural fires, the collapse, and exacerbation of medical conditions. The agents added to explosives, when they tried to blow up the World Trade Center the first time, they tipped the bombs with anthrax, but didn't understand that the heat generated by the detonation of the bomb destroyed the anthrax. But radiation might be something that would be considered, not so much bacteria or anthrax or something like that. Dirty bombs refer to a small suitcase where some low-grade plutonium is placed in there. the injury is not going to be from the plutonium or the radiation. The injury is going to be from the primary blast wave. And then, of course, exacerbation of medical conditions. Make sure that the scene is safe when you're dealing with explosive sites. Be really leery that perhaps you're dealing with a terrorist attack. A concept that they'd like all EMS providers to understand is burn to bomb, bomb to burn. Bomb to burn, burn to bomb. That's what it is. Bomb to burn, burn to bomb. So a bomb starts a fire, everybody arrives, and the burn ignites a second device, wiping everybody out that responded. It has happened, at least over 10 times in the United States in the last decade or so. So it's a concept we need to be aware of. Look for a potential secondary explosive device when you arrive on scene of an explosion. Comply with law enforcement orders, deal with immediate life threats, including hemorrhage control, airway management, rapid transport, particularly if you're dealing with blast lung. Cavitation is directly related to the ability of tissues or organs to return to the original shape. Permanent cavities are produced when the force exceeds the tensile strength of the tissue, as in the case of a projectile from a weapon. Ballistics is the energy of the object into the surrounding tissue determines the effect on the body. And when we look at the principles of kinematics, what they're referring to here is the speed of the projectile. The faster the projectile is going when it enters the body, as it slows down, the body has to absorb more kinetic energy, and the injury is worse, or the damage to the surrounding tissue is worse. There are 3 levels of velocity. There's a low level velocity injury, a medium velocity injury, and a high velocity image. Stab wounds are considered low velocity, ice pick stab wounds, but do understand that if a knife goes straight in, straight out, there's going to be one track of damage, but if a knife goes in and then the handle is moved around while the blade is still inside the body, you get a cone effect. So even though the stab wound may be in the abdomen, it may involve the thorax, or it's in the thorax, it may involve the abdomen. When law enforcement officers or those EMS providers that work in really hostile environments are wearing body armor, when struck with a medium or high energy projectile, that can cause internal trauma to internal organs from a rapid jolting force leading to a shear type injury. The wounding forces of medium and high energy projectiles, the projectile travels through the air, a sonic wave spreads out behind the missile, which is what causes the cavitation. The speed of sound in tissue is 4 times the speed of sound in air. The mass of the projectile, how large the bullet is. Tissue crush is limited by the physical size of the projectile. If the bullet strikes point first, the crush area is no larger than the diameter of the bullet. But if the bullet is tilted or enters straight up and down when it hits the body, the crushed tissue is no larger than the length of the longitudinal cross-section of the bullet. Again, upper left would be handguns. Those would all be considered medium velocity weapons, and rifles down below from 22s on up would be considered high velocity weapons. Deformation refers to some bullets that flatten on impact, and in those particular situations where the bullet mushrooms on impact, the bullet diameter expands, creates a larger area of crushed tissue. Tumble refers to whether or not the bullet stays on a straight and narrow path, or whether it tumbles through the air, and as it tumbles, depending on the profile when it strikes the tissue. If the bullet goes straight in and remains on a straight path, then the energy is restricted to that path. But if the bullet changes direction, either inside the body, as illustrated here, then the cavity is going to increase um, as the projectile stands upright here. Fragmentation, when the missile or the bullet breaks into smaller pieces upon impact. Each one of those pieces will cause cavitation. And again, the higher the velocity, the more likely the bullet will fragment into multiple pieces. And there may not be any exit wound in that particular case, but there would be multiple cavitation tracts. And again, the type of tissue that's struck determines the significance of the penetrating trauma as well. Whether you're dealing with air, water-filled tissue, or solid tissue or bone. Here is an example of fragmentation. The projectile enters the body, breaks into smaller pieces. And on X-ray, you can see the multiple pieces when it struck the rib there, and each one of those has a cavitation track. Striking velocity. Low velocity weapons have little disruptive effect. That's your knife pick or your knife or your ice pick. High velocity weapons can cause serious injury because of the higher energy transfer to the tissue that occurs, and it's all related to speed. Range, how far away you are from the projectile, certainly has an effect on the type of damage that it's going to cause. Drag is something that occurs as a result of air and gravity. Will slow the projectile down, and at some point it will stop. The force of gravity exerted on the projectile as it travels is known as drag. If the firearm is discharged at close range, then cavitation occurs, and then you'll have combustion of powder and forceful expansion of gases as the bullet leaves the guns as well. Shotgun wounds, short range, low velocity weapons, multiple lead pellets. They can be steel, they can be lead, inside a shotgun shell. They contain a plastic or paper wad, which if it gets into the wound certainly is a potential for infection. The energy transfer and tissue damage depends on the gun gauge. The larger the number, the smaller the shell. So a 20 gauge is much smaller than a 12 gauge. The size of the pellets, you got double-aught pellets all the way up to eights. And they're the larger the number, the smaller the pellet. Powder charge, how much gunpowder is packed into each shell determines its punch, and then how far away you are from the target. Here's an example of some penetrating trauma from gunshot wounds. With shotguns, you can have contact wounds. The barrel of the shotgun in direct contact with the patient can cause a wound. The area around the wound can be burned. You can have widespread tissue damage. Contact wounds from a shotgun, in other words, a shotgun blast at really close range. High mortality rates, 85 to 90%. They create a circular entrance. They may have gunpowder and residue. And that gunpowder and residue, the wad, may penetrate deep beyond the fascia. Intermediate range wounds, they're wider spread because as you get further away from a shotgun, the pellets have a tendency to spread out depending on the choke, and you'll have a definite entrance wound surrounded by smaller wounds from the individual pellets. Deep and superficial wounds without gunpowder residue occur here. And then long-range wounds are very widespread. Type 1 wound is defined as barrel is greater than 7 mils. Type 2 wound, the barrel is 3 to 7. Type 3 wounds, the barrel is less than 3. Some things that affect whether or not you have an exit wound certainly include range, barrel length, caliber, powder, the weapon used. Um, you'll often have the entrance wound is going to be the size of the projectile as it enters the body, whether it be straight on or straight up and down. And then powder burns if you're close enough, leaving that noticeable what they call tattooing, as that gunpowder is penetrates deep into the skin. Exit wounds are larger than the entrance wounds because of that cavitation. As the projectile exits, the skin explodes. It's ragged and torn on that end. A starburst or stellate appearance to it. The gases that enter the tissue when you're shot, at close range also can cause crepitus and burns if at close range as well. There's an example of penetrating trauma from a projectile from a bullet, and you can see the tattooing and the burning of the skin in that second, or the slide on the right. Special considerations, headshots. If there is no exit wound, there can be direct destruction of the brain tissue from the projectile itself, and then certainly secondary brain injury from things like swelling and bleeding inside the head. Things to keep in mind about head injuries, particularly face and neck. Face is very vascular. You could have some major blood loss from scalp bleeds or facial bleeds, but typically when you're dealing with face and head injuries and your patient is shocky, look somewhere else for the shock, because it's often not caused by those. However, the patient may have difficulty maintaining an airway with a head injury. If they've got trismus, their jaws are locked, you can't get their jaws or mouth open, you may have to intubate them intranasally. And they may have spinal cord instability, and you may need to require some sort of spinal mobilization. With medium energy projectiles, the energy absorbs within the cranium closed space. It compresses the brain tissue against the cranial cavity and produces plates or sections of bone. High velocity wounds, massive destruction because of the cavity. A piece of the brain of the skull is destroyed. If the weapon is held in contact with the head, the gas is going to follow the bullet into the cranial cavity and have an explosive effect. Thoracic injuries, injuries to the pulmonary and vascular systems. You can have pleura and pulmonary parenchyma disrupted, leading to a collapse of the lung, or a pneumothorax, hemothorax, tension pneumothorax, leading to a shift in the mediastinum to the unaffected side. You can have massive internal and external hemorrhage in the chest. You can also have a hemothorax, a myocardial rupture, pericardial tamponade. Abdominal injuries usually require surgery to determine the injury extent, but you've got multiple organ systems within your abdomen. You've got air-filled systems, you've got solid and hollow organs, and all of those can be damaged as a result of a gunshot wound to the abdomen. If somebody is shot in the abdomen, assume they have a serious life-threatening injury. Extremity injuries, damage to the nerves, the muscles, the bones, vessel injury causing hemorrhage. Assess the extremity like you would any other potential extremity injuries, with circulation, motor, sensory testing, control hemorrhage. And when a bullet strikes a bone and the bone shatters, those bone pieces also become secondary missiles or bullets themselves. And there's a representation of that. Non-lethal or less than lethal weapons include your handheld non-electric devices, your handheld electric devices, rubber and plastic bullets, and shoulder-fired munitions. The general principles of management of trauma include scene signs up, making note of mechanism of injury to determine the potential for a life-threatening injury. Look at body position, look for severe hemorrhage, look for the potential of head injury, listen for abnormal sounds with respiration, look for obvious respiratory compromise, whether or not they're moving spontaneously, treat immediate life threats, which would be anything to do with airway or significant hemorrhage. Limb threats could be, no blood supply to that particular limb, but limbs can go several hours without a blood supply. Injuries that could result in severe function or loss of disability, injuries that will not result in loss of life, limb, or function, and traumatic cardiac arrest. So if I'm prioritizing who I'm going to treat first following major trauma, those with immediate life threats I'm going to treat first, those with limb threats I'm going to treat second, those with injuries that could result in severe function third, those that won't result in loss of life or limb fourth, and then traumatic arrest last. Your primary survey begins with your A. Open the airway, use a trauma jaw thrust. Remember that snoring, gurgling need to be addressed with opening the airway and suctioning. Look for foreign objects. Use the simplest effective measures, and that will save you more time that you just don't have by trying to intubate the patient on scene. If you can ventilate the patient with a BVM and move them quickly to the ambulance and then intubate them in or out, you're far better off than spending that time on scene. Breathing, determine the effectiveness of the breathing. Rate rhythm and quality, as well as expose the chest to look for holes in the chest, look for unequal chest rise, tracheal deviation, excessive muscle use, get a respiratory rate, check their SATs, check their end-tidal CO2, look at their neck for JVD, and their trachea for deviation. Circulation, assess their color, temperature, and condition of their skin while you're looking at their breathing, checking a carotid pulse in unresponsive patients, or radial pulse in responsive patients. You're looking for the rate, the rhythm, and the quality of the pulse. Assess capillary refill, which isn't really a good indicator of circulation, but they continue to tell us to check it. If a person is bleeding externally, we need to control that immediately with either direct pressure or tourniquets. Examine the abdomen or the pelvis and the femurs for signs of internal hemorrhage. Abdomen will be distended and guarded. The pelvis, you're really not going to know unless they complain of pelvic pain or have some pelvic instability when you compress the pelvic rim. The femur will just swell. Your disability is part of your primary survey, and here you're doing neurochecks. So initially it's ABPU, get their response to stimulation, and then later get a baseline Glasgow Coma scale, assess their pupils, their circulation, motor, sensory, palpate the spine for step-offs, crepitus, and apply a cervical collar. E is expose. Look over the remainder of the patient's body for hidden injuries, and remember not to make them cold, because cold in trauma is bad. So we're going to expose them, but then we're going to immediately recover them up. Your secondary survey, if you can do it, and there's time to do it, allows you to do a more detailed assessment, get multiple sets of vital signs, a good medical history, and then continue to monitor and reassess. When you're dealing with a patient who has life-threatening injuries, you certainly can use a long spine board to move a patient from point A to point B. You can use a scoop stretcher, but you identify a life-threatening injury, you may spend a little bit of time on scene trying to rectify that, and all other further treatment like IVs and those sort of things can be done en route. Remember, you've got that 10 minutes, and it is so important that once we gain access to the patient, if we can have them out of there in 3, that'd be awesome. But we should take no more than 10. Alright, so that finishes our section on kinematics and traumas. So if you have any questions, you know how to get a hold of me, and I'll be talking to you soon.